So I did my research on posterior ankle injuries in dancers and specifically what are the treatment options and the outcomes of them. So just some background information. Foot and ankle injuries are almost inevitable in dancers. Dancers exert such a large amount of stress and force on their lower extremities. And because all of that stress that's being exerted on the foot and the ankle, small and large injuries are almost always going to occur. To be a dancer that dances on point, they must have adequate flexibility in the foot and the ankle complex. So flexibility is needed to achieve full point and achieve proper placement to lower the chance of injury. The flexibility in the ankle requires an extreme amount of plantar flexion of the talocrucial joint. An average degree a ballet dancer needs for their ankle range of motion for plantar flexion is 90 degrees. And to put that in perspective, a non-dancer's normal range of plantar flexion is anywhere just from 20 to 50 degrees. Up to 50%, 57% of injuries in dancers are related to the foot and the ankle, and a significant contributing factor to this is the fact that dancers are placing up to 12 times their body weight compression force is being applied when a dancer goes up on point. This leads to the repetitive peak stress on the bony structures in the back of your ankle, and it may contribute to two of the most common types of ankle injuries in dancers called posterior ankle impingement syndrome, or PAIS, or flexor hallucis longus tendinopathy. And this is just a picture of a dancer up on point, and you can see right in here that the ankle needs to be at about a 90-degree angle to fully be able to go up on to the shoe. And then this is on the right side, this is a dancer just on releve, kind of the same thing, except the dancer is just not fully up on their toes. And then this is also a picture of the talocrucial ankle joint. You can see right here, that's where all of that flexibility for plantar flexion is needed. So posterior ankle impingement syndrome, or PAIS. This is one of the most common types of injuries in dancers, and it's because of all of the force that's being exerted on the bony structures in the ankles. And this condition is, which pain is experienced at the dorsal ankle because of the hypoplantar flexion. And not only is this condition common in dancers, but it's also common in activities that involve repetitive plantar flexion, such as soccer, cricket, high jump, long jump, and many more. But of those activities, dance accounts for 62% of the prevalence of PAIS. Many of the causes of PAIS can be categorized as osteostructures that are potentially causing symptoms during the plantar flexion. And those symptoms can just be ankle pain, tenderness, ankle pain when you're walking, when you're dancing, kind of just any type of pain in the back of your ankle. And an osteos can occur when the dancer is on point or releve, and this is called an ostrigonum. An ostrigonum is usually a result of a secondary ossification center, and this is where the ossification is occurring at another location of the bone. The ossicle is supposed to fuse to the talus, forming the posterolateral process of the talus. But in high training dancers, when they attempt to fully point their foot or go on to point, the ossicle is caught between the posterior tip of the tibia and the talus. And this is a result of the accessory bone that's being impinged in that spot, and this causes ostrigonum syndrome. This is actually a picture of my ankle when this happened to me a few years ago, and you can see right where the arrow is pointing, that is that accessory bone that I had to get removed, but each time that I would go up on point or just point my foot, that would be caught in, it would be impinging, and it was just a lot of pain. So the next most common type of injury in dancers is flexor hallucis longus tendinopathy. This is classically known as dancer's tendinitis, and it's rarely seen in other activities besides dance and ballet. The FHL tendon is responsible for the flexion of the hallucis at the interphalangeal joint, and it's also responsible for plantar flexion of the foot at the ankle, but mostly to flex the hallucis. The tendon passes through a fibro-osseous tunnel from the posterior talus along the medial aspect of the foot and then onto the plantar surface of the foot. So if a strain occurs, there may not be able, or the tendon may not able to move smoothly in the tunnel, which can then lead to irritation, swelling of that tendon. The FHL tendinopathy can be an isolated entity, but can also coexist with PAIS. And in dancers, FHL tendinopathy can coincide with PAIS, and it accounts for up to 63% of the impingements. And then the FHL tendinopathy in dancers, it's not really fully understood how it happens or why, but it's possible that it may be related to anatomical deviations, faulty dance techniques, and then possibly FHL activity in certain positions or jumps. So I researched the treatment options to treat both of these type of injuries. So the first treatment options that doctors usually recommend and have dancers do is just a conservative treatment. So these treatments usually is a correction of the dance techniques and alignment, a period of rest modification, and physical therapy, and then use of anti-inflammatory drugs. And if it's possible for a dancer to rest for a few weeks, they'll most likely be placed in an controlled ankle motion boot to help settle the inflammation, so you're not constantly moving that ankle while walking. And once the dancer is able to walk pain-free, they can start a return to dance habilitation program and then return to dance. But in some cases, dancers are not able to rest for the required time and to determine if this approach will work to resolve the pain. Dancing is not just seasonal training, as performances and training occur all year round. However, some dancers may be able to find a window to allow for that rest and recovery period based on the schedule of their company and performances. But for competitive dancers, January through June are the most important times of the season, and there's really no rest period in there. And then all of the other months, you're training and practicing leading up to the competition season. So there's really not a good rest period to have. And when a rest period is not an option, there are other more invasive options are considered. So continuing with that, if the conservative treatment doesn't work, the next step would be to do a guided cortisone injection into the soft tissue behind the ankle. And when the patient is administered the cortisone injection, it's not to completely treat the diagnosis, it's only to resolve the pain. And after the injection, if they are pain-free, they start the rehabilitation, physical therapy, they're able to go back to dance. But if the symptoms do not resolve, surgical intervention may be necessary to correct the issue. So there are two main types of surgery techniques when it comes to treating the posterior ankle impingement syndrome and flexor hallucis longus tendinopathy. And those techniques are either through an open approach or an endoscopic approach. The traditional surgical technique is an open procedure, either a lateral or medial approach. And the lateral approach is used when the diagnosis is limited to posterior ankle impingement syndrome by a bony process, such as the os trigonum. The hindfoot endoscopy enables an overview of the intimate relationship between the os trigonum and the posterior ankle impingement syndrome and the flexor hallucis longus tendon, because usually they coincide with each other, so it allows for good judgment of the posterior ankle pathology. The endoscopic technique has been increasingly popular to treat these diagnoses because it's less invasive, it has a reduced risk of complications after surgery, a shorter recovery, and better clinical outcomes for dancers. Both PAIS and FHL tendinopathy can be treated with the endoscopic technique with very few complications. And endoscopic approach uses a flexible tube with a camera and a light on it to be able to see the area, and they only have to make 2 little incisions in your ankle, usually on the medial and the lateral side, but they're very small. And then a surgical probe is in the other incision, and then it does the correction of the injury and then the removal of the bony process. And then this typically only leaves 2 very tiny scars. And then the other surgical option is through an open approach. In the open surgery, when the open surgery is done, the patient is cut about 3 centimeters on the ankle, usually on the lateral side of the ankle. And while fixing the PAIS syndrome in FHL tendinopathy, the doctor has to cut the tendon sheet of the FHL tendon about 2.5 to 3 centimeters. Then the bony process is removed and the FHL tendon is cleaned up and the incision is closed. And so the post-operative treatment for both of these surgical techniques are the same. After the surgery, the ankle is wrapped in a compressive dressing or splint with weight-bearing restrictions for about 1 week post-operatively. Some can be less, some can be more. Once the splint is removed, a controlled ankle motion boot is used. The patient starts a dance-specific physical therapy plan to regain range of motion, and weight bearing is allowed as tolerated. And most dancers fully return to dance around 6 months post-surgery. So the methods I used while researching. While I was researching my question, I used 4 databases: Sports Discuss, PubMed, Science Direct, and Medline. And then the terms I used were dancers and posterior and ankle, and dancers and ankle and physical therapy. I limited my search to only English articles. Full articles had to be available, and then the study from 2010 to 2021. And then from those databases and limitations, I was able to find 37 articles that fit my criteria. And then from those articles, I found 9 that were single study articles. 3 were related to the management and evaluation of the posterior ankle impingement syndrome and flexor hallucis longus tendinopathy and conservative treatment options. And then 6 were related to the operative options, whether it was the endoscopic or open approach, and the results of those surgeries. So for the conclusion and the outcomes, I found that dancers who suffer with posterior ankle impingement syndrome and flexor hallucis longus tendinopathy only really have 2 options to completely treat and take care of the injury. They have the conservative treatment or the surgical treatment. Specifically for the surgical approach, I found that the endoscopic technique is recommended surgery for those dancers. And this is the best approach because studies have shown that it's less invasive, reduce the risk for post-operative risk after the surgery. Dancers get back to dance faster, and then the dancer is able to get back to dance at the same level before the surgery and before the injury. And that is probably one of the most important things that a dancer would want.